Hello, everyone. My name is Dr. Prakash Krishnan. I am an interventional cardiologist and the Director of Endovascular Intervention at Mount Sinai Medical Center, New York. I'm part of a 5-person full-time group here at Mount Sinai Medical Center. We are one of the busiest labs in the nation, and we see a varied number of both coronary and complex endovascular cases. I'm happy to present 2 cases to you, through which I hope to discuss the use of intravascular ultrasound in endovascular intervention of infrainguinal disease. Patient number 1 is a patient that we all share. It's a 63-year-old female with a history of non-insulin dependent diabetes mellitus, coronary artery bypass graft, hypertension, and hyperlipidemia. She presented with classical symptoms of intermittent claudication localized to her left calf greater than right on walking approximately 2 blocks. As part of the standard workup here at Sinai, we performed resting ABIs and exercise ABIs. Resting ABIs revealed a relatively normal ankle brachial index at rest. On the right limb, it was 0.97. On the left limb, it was 0.87. We then proceeded to perform an exercise ABI using the modified Bruce protocol in our vascular lab. After the patient exercised for 1 minute and 41 seconds, the patient's ABI on the left dropped to 0.67 with pain making her stop exercising, clearly unmasking the underlying disease. After the results of the exercise ABIs were found, the patient was started on a trial of Pletol, which she failed, and therefore she was referred for peripheral angiography at our lab. Peripheral angiogram was performed, and you can see here on this DSA image on my screen. This is a selective injection of the left superficial femoral artery. You can see here at the level of the mid-distal or the mid to distal SFA, there's a focal high-grade stenosis that would clearly cause the symptoms that this patient is having. Considering the length of the lesion and the location of the lesion, it was determined that endovascular intervention would be appropriate for this patient. Atherectomy was the device modality chosen to treat this patient, and we went ahead and performed atherectomy using the standard technique. The choice of atherectomy we chose here at Sinai was directional atherectomy. After directional atherectomy was performed, you can see that we clearly have a lumen, and the lumen size is clearly increased compared to our pre-picture. However, what was concerning was this hyperlucency that you see here, almost a double lumen type shadow that was very concerning to us upon completion of the atherectomy. With this kind of appearance, we were concerned about a few things. First of all, we did not know whether there was a severe dissection at the site, whether there was a contained perforation, or whether there was a hematoma. Since we had done directional atherectomy, which is virtually a blind type of atherectomy where you cannot visualize where you're cutting, we decided to do an intravascular ultrasound because of this angiographic appearance. Once we placed the intravascular ultrasound catheter into the body and we did an IVUS run at the site of the lesion, we were surprised by what we found. Though we followed standard atherectomy technique by cutting all 4 quadrants, we unfavorably, in this case, cut 1 quadrant more than the others. And this is clearly seen by the IVUS, which shows all 3 layers, the intima, the media, and the adventitia, being gouged out in this particular angiogram. So therefore, the angiogram that we saw left us with a lot of doubts. Number 1, do we leave it alone? It's a non-flow limiting dissection. Can we leave it alone? Or number 2, more concerningly, is it a contained perforation or an intramural hematoma? But once upon seeing this intravascular ultrasound, we were convinced that this needed to be treated in order to prevent delayed aneurysm formation. So therefore, we treated this with a covered stent, and due to the patient having 3-vessel runoff, we were not as concerned about stent thrombosis as we normally would be. Therefore, in this particular case, IVUS gave us the answer to what we could not decipher by standard angiography alone. What we were shocked at when we got the histopathology back was that we clearly cut normal tissue. So you can see here, this is the histopathology of the same patient. We've taken both the intima, the media, and the adventitia. However, what was surprising to us was that the area we cut had really no atherosclerotic plaque burden. So directional atherectomy, though we did standard technique, may not have been the right way to treat this patient. So again, this is a zoomed up slide, again showing you both the intima, and you can see the intimal area does not have much plaque. the media, and the adventitia, all three layers. So it's a through and through cut, necessitating that we do another form of treatment. So in this particular case, intravascular ultrasound helped us in discerning and diagnosing what we could not diagnose with standard angiography alone. We were able to diagnose that this patient had a through and through cut, which was confirmed not only by IVUS, and also with histopathology specimen. So this in turn helped us treat the patient properly by using a covered stent rather than a standard stent in this patient, which hopefully will prevent late aneurysm formation at this site. The second patient is a 74-year-old male with a history of non-insulin dependent diabetes mellitus, CABG, hypertension, and hyperlipidemia, much like our first patient. However, this patient also presented with one block claudication. Upon workup of this patient, we did resting ABIs, which were 0.97 on the right and 0.74 on the left. As per our normal protocol, we sent the patient for exercise ABIs. The patient exercised 1 minute, 1 second on a modified Bruce protocol with his ABI on the left dropping to 0.54 and the patient stopping exercise with pain. Again, the patient was started on Pletol as per the standard dose, and we tried exercise therapy for approximately 3 months. The patient failed within a month of exercise therapy and wanted to have alternative therapy. So we brought the patient to the cardiac cath lab. Diagnostic angiography was performed, again using standard DSA techniques. And here we again placed the catheter in the superficial femoral artery and did a selective angiogram of this particular lesion. The catheter is placed at the level of the left common femoral artery, and DSA images of the left SFA are obtained. They clearly demonstrate a high-grade 90% or so lesion at the level of the mid-distal SFA, right before what would be the adductor canal. The patient had 3-vessel runoff. However, with the tight nature of this lesion, it would clearly explain his symptoms of claudication. This patient was treated just after the last patient that I presented to you. Thus, we decided to perform intravascular ultrasound after each directional atherectomy cut. The results were quite astonishing. We did an IVUS prior to doing atherectomy, and you can see in the pre-IVUS run a very, very tight lesion, atherosclerotic, a fibrocalcific plaque, which was basically around the catheter. It's very, very clear in this intravascular ultrasound image. So it is a concentric plaque. It is not eccentric. Therefore, it should be amenable to directional atherectomy. Here I've decided to present it in 2 images. First is the first pass, and our atherectomy technique is pretty much standard to what everyone around the country performs. We start usually facing the lateral wall, which in this case would be against the bone, and we do 1 pass. After that pass, we did an IVUS, and again we labeled it lateral. We did an IVUS, and you can see we really did not make an indentation into the plaque in this particular pass. We then went ahead, and again, not knowing whether we were anterior and posterior, we clocked 6 or 8 times till the atherectomy catheter was facing us. Then we did a pass, and you can see directionally we were able to make a cut, not cutting the adventitia or the media. Our next pass was medial. Again, you can see, even though we were pointed medially, we cut in the same plane, thereby showing that angiography alone is not enough to know exactly where you're cutting with the directional atherectomy catheter. Because if you compare this IVUS specimen to the one prior, you can see we just increased the cut in the same direction. So that taught us that we should not cut in this direction, because as per IVUS, we are very close now to the media and the adventitia. So we did not want to cut in this plane. So we went ahead and did either anterior or posterior with the atherectomy catheter facing us. And regardless, even though we did that, we still cut almost in the same plane. So this may be because of the toggle of the catheter. This may be because of the way the catheter moves and that we're unable to control the atherectomy catheter. We went ahead, very carefully, cut again in the anterior or the anterolateral way, and you can see angiographically we were done. And we confirmed this in two separate views. However, IVUS-wise, you see that we've clearly increased the lumen, okay? But we've left behind considerable amount of residual plaque. So therefore, it's very clear in our final cut that no matter what we try to do in terms of pointing the catheter, whether it's anterior, posterior, or lateral, the catheter seemed to, for the lack of a better word, gutter back into the same plane. But here, clearly, as angiographically and IVUS-wise, our lumen was much better. The patient had a palpable pulse at the end of the procedure, which he did not have prior to, so therefore we decided to stop the procedure. This patient has been seen in follow-up with me now for 3.5 months. The patient is significantly better, walking anywhere from 8 to 10 blocks without pain. So clinically, we had a success, but in this particular patient, intravascular ultrasound helped me know what I was doing inside that vessel. As you can clearly see, no matter how I torqued the catheter, whether it was medial, lateral, anterior, or posterior, I was still cutting the same plane. And if I had continued to cut the same plane, I would have in all likelihood caused another through and through cut or dissection. So therefore, in this particular case, I knew when to stop, and I was satisfied in knowing that I had not disrupted the media or the adventitia. I hope that these two cases illustrate the varied uses of intravascular ultrasound in endovascular intervention for peripheral arterial disease. In our cases, the first one and the second one, IVUS both helped us diagnose and direct therapy, telling us what type of therapy to use in the first case and when to stop in the second case.